you stand. Then you stand.
For people with cerebellar ataxia, the task of a sit-to-stand can be very difficult and intimidating to perform, especially when they must utilize little external support. A common impairment for this population of patients is dysmetria. Dysmetria is a condition in which the patient overshoots movements due to lack of appropriate deceleration contractions. As we move through the phases of sit-to-stand, you can see how dysmetria influences their standing technique. In the flexion momentum phase, the patient requires multiple forward leans with upper extremity involvement. Because of their dysmetria, the forward lean is exaggerated in this population, and the trunk does not eccentrically control the forward flexion. The patients begin with a wide base of support and use their upper extremities to help increase their balance. The momentum transfer phase happens quickly for these patients as they depend heavily on momentum due to their decreased mid-range control. The trunk is a key structure that is utilized in a sit-to-stand, and because these patients have decreased trunk control, the motion appears novel. Like the momentum transfer phase, the extension phase also happens very quickly. They continue to use external support for balance, and the trunk briefly hyperextends as opposed to going strictly upright. The hyperextension of the trunk happens in an exaggerated fashion due to their inability to produce and control a fine-tuned movement. Compensatory stepping may also be seen in this stage to help control their center of mass over their base of support. For the stabilization phase, the patient appears extremely unsteady. Their base of support is wide and their trunk sways in inconsistent directions. Overcorrections are attempted, causing the patient to be at further risk for loss of balance. Ankle and stepping strategies may be seen in their lower extremities to help maintain balance. A high guard position may also be utilized in their upper extremities to sustain proper balance, and external support may be needed for safety. For the task of sit-to-stand, we identified dysmetria as the major impairment. NDT techniques focusing on approximation and tactile cues are used to help control the motion. The NDT techniques are especially important in the stabilization phase during sit-to-stand to help alleviate the overshooting and overcorrections that can obstruct the patient's safety. Because these patients have a hard time controlling motions, the first treatment utilizes a counted cadence and decreased speeds to help organize the movement. During this intervention, the patient learns how to rise from a chair by associating a movement with a number. During number 1, the patient bends their knees and places their feet under their chair. At 2, they bend their trunk forward. At 3, they rise by straightening their hips, knees, and then trunk. And at 4, they focus on maintaining stability. When they reach the final step, the therapist may need to utilize approximation at the hips to facilitate a co-contraction needed for stability. The NDT decreases once the patient gains stability. The task can be made harder by having a patient stand from shorter chairs or performing the movement with their eyes closed. The next treatment focuses on control by having the patient perform slow and steady mini squats. By performing this closed chain motion slowly, the eccentric component is emphasized. Because dysmetria is oftentimes due to improper eccentric contractions, this skill may help in facilitating proper muscle firing techniques. The chair placed behind the patient serves as a visual cue and a safety mechanism in case of imbalance or fatigue. In the beginning, the patient may need some tactile cues from the therapist to encourage proper pelvic position. As you can see, tactile cues at the stomach are being utilized in the video during the stabilization phase. These cues can help encourage trunk stability and prevent the patient from achieving an anterior pelvic tilt. Both of these treatments utilize work in the whole task movements, which research has shown to be much more beneficial.